Welcome to Pharmaceutical Calculations, a conceptual approach, lesson 24, Fluids and Electrolytes, part 1, Electrolyte deficits and fluid shifts. Now, this is certainly a very big list of objectives, and I'm not going to read through the whole list here, but I can assure you that I'm going to discuss every single objective in this list. Now, why studying together fluids and electrolytes? Why not studying each one separately? Because as we already know, body fluids contains solutes, and some of these solutes are, of course, ions. The word electrolytes here is because of the capacity of these solutions to conduct electricity, and usually electrolytes involve ions. Okay, now as the title implies, deficits, electrolyte deficits, will affect our body fluids. So this is why we study them together. And obviously, fluids and electrolyte imbalances are very serious and can cause very serious conditions in our body. Now, obviously, our final goal is to learn how to carry out calculations related to electrolytes, and this is why the course is called Pharmaceutical Calculations. However, we need to be able to have an understanding of why are we preparing these solutions. That's why these first two lectures are introductory background information about fluids and electrolytes. Now, in this first slide over here, I've included basically three different ways that we can actually get into our body: liquids, fluids, and basically water and electrolytes. And this last one over here is how our body eliminates water and electrolytes. So basically, we need to understand that our body cannot synthesize ions. In fact, nobody can synthesize ions. That's atoms, right? So we get electrolytes in our body through food and drinks. And of course, we also get water in our body by drinking it. But about water, cells can actually produce water during the degradation of organic nutrients. But this metabolic water is only a small percentage of the total water intake, about like 10 to 15%. So this is how we get fluids and electrolytes into our body. We cannot synthesize, again, ions, right? Now, water elimination from our body takes place mainly through four organs. Kidney, which in fact, kidney does not only eliminate water and electrolytes, it also regulates their presence in our body, okay? Now, intestine, lungs, and skin, they help eliminating or they are used to eliminate fluids and electrolytes, but they do not control their elimination, okay? So this is very, very important for us. Okay, now serious perturbation of electrolyte balance will result in fluid imbalance. And again, this is related to osmosis. We understand that when we reduce the concentration of solutes in solution in body fluids, the water concentration also will change. Now, this imbalance will cause our body to initiate various activities to restore homeostasis, and we're going to study some of this later in this lecture. Now, the major organ that is implicated in the restoration of water and electrolyte imbalances is the kidney, as I mentioned last time. So kidney is the organ that is involved in the regulation of water and electrolytes in our body. So kidneys, they regulate water and electrolytes by excreting excess inorganic ions out of the body and reabsorbing those ions that the body needs. And they also help regulating water, of course, via hormones and other chemicals, by eliminating water in the urine or reabsorbing water, depending on the needs of our body, okay? Now, we also need to understand that our body organs, like kidney, for example, can restore only mild fluid and electrolyte disturbances. when the disturbance or imbalance is very serious, then there needs to be a clinical intervention. So we need to supply fluids and electrolytes externally to these patients, okay? Now, disorders and conditions that distort the balance of body fluids and electrolytes should be treated by a concomitant correction of fluid volume and electrolyte deficit. So you need to see both, not just one of those, okay? And this involves certain conditions and disease states. So therefore, as clinical scientists, we need to be aware of all these maintenance fluids or replacement fluids, because the choice of which one do you administer and at what concentration is very important to correct the particular condition, to remedy the particular condition. And here I have a representative list. I've reduced the font to include some of the most common solutions that are used in fluids and electrolyte conditions. And here I have isotonic saline. So these are, of course, electrolytes, right? So this is sodium chloride. Sodium chloride. So this is isotonic, and obviously isotonic is we have it here, so I don't need to rewrite it. This is a hypotonic saline, okay? This is a hypertonic saline, 3% saline. Here I have dextrose, isotonic. Here I have hypertonic dextrose, D10W. Here I have a mixture. So this is an isotonic solution containing 5% dextrose and 0.9% sodium chloride. Here is a famous one, Hartmann solution, Ringer solution, and WHO. This is very, very important. It's for oral administration, especially for kids that suffer diarrhea. And here I have, so what we have just described are called crystalloids. And we're going to talk about crystalloids in detail in a minute. And this list over here contains polymers, which are called colloids. And what do we have here? I believe this is the only one that is a biological macromolecule, right? Our molecule, human serum albumin, 5%. Here we have 20% human serum albumin. We have dextran, that's synthetic, or sometimes it's actually from seaweeds. We have voluvin and elohase. Okay, so these are sugar molecules. Again, high molecular weight. So now this is a representative list of maintenance and replacement solutions. Okay. First, let's go through our body fluid compartments. We need to get familiar with the body fluid compartments first, because that's where the electrolytes dissolve, right? Now, for normal adult individuals, body fluids are about 50 to 60% of our total weight, whereas in infants, the total body fluids are actually much higher, 70 to 75% of their weight. And this is an important information, especially in pharmacokinetics, because there is this so-called parameter called volume of distribution of the drug, and you need to be familiar with the percent body fluids, okay, in order to adjust the dose correctly in these special patients. Okay, now what is our body fluids compartment now? Perhaps I can move into a schematic. Let's stay here for a minute or two. So in general, our total body water can be divided, or body fluids can be divided into two major compartments, the extracellular fluid and the intracellular fluid. So let's move to the schematic. I think it's much better. So here we are. For a normal, a regular adult, I would say, not normal, a regular adult, which is about 70 kilograms adult, the body fluid would average about 41 liters, and we have two major compartments, extracellular, as the word implies, this is fluid out or outside of the cells, right? Which is 35 to 40%, and intracellular fluid, which is 55 to 60%, so about twice as much, let's say. So here is the schematic. we see that the interstitial fluid and the intravascular fluid, this is the central circulation obviously, is about 13 liters. We have 2 liters of blood. So this is the extracellular fluid. So the extracellular fluid is further divided into interstitial fluid and intravascular fluid. For a regular adult of 41 liters body fluid, the extracellular fluid sums up to 15 liters. Out of these 15 liters, 10 liters is the interstitial fluid and 5 liters is the blood. And of course, in the blood we have red blood cells, white blood cells. These are about 2 liters. We have 3 liters of plasma. So our body fluids, our extracellular body fluids, for a regular adult, let's say, a normal weight adult, is 10 liters of interstitial fluid, that goes to tissues, but is still close to the blood circulation, separated by the leaky capillaries, right? And 3 liters, which is the plasma, of intravascular fluid. Now notice the discontinuous line that I have here. This is to tell you that the capillary endothelium is quite leaky, and basically every small low molecular weight solute can leak out and exchange into the interstitial fluid. So the composition of the interstitial fluid and intravascular fluid is similar, except from the red blood cells, okay? Except from the blood cells and some of the proteins, some of the colloids. Colloids and cells usually stay in the central circulation, okay? Now the intracellular fluid is about 26 liter for a 70 kilogram individual. And of course it is the fluid that is inside the cells. All right? Okay. Now let us discuss the composition of body fluids. And here I'm referring to solute concentrations. Now to the top, so this panel over here contains crystalloids. And this term is rather very hard to understand. But most of the compounds, or most of the compounds contained in the top panel are actually electrolytes, are actually ions. So we can see here, this column contains the extracellular fluid, which is intravascular and interstitial fluid together, okay? And this is of course the intracellular fluid. And the top panel contains the cations, and this panel contains the anions. Now you can see here that sodium ion is predominantly in the extracellular fluid at the highest concentration, whereas potassium is predominantly intracellular. Of course, potassium is, as we know, or perhaps we need to learn, is a very efficient poison. So if it is in the blood at high concentration, it stops the heart, right? And then we have also some concentration of calcium and magnesium, which are bivalent ions. Notice that the concentrations written here are milliequivalents per liter, or millinormal, okay? Millinormal. Now we know that normality is equal to N times molarity, and this is basically, N is usually the valence. So if you're gonna convert milliequivalents per liter into molar, you know how to do that by dividing by the valence of each ion. For monovalent ions, of course, it's going to be the same number. Now, with respect to anions, electrolytes again, we have chloride, and of course sodium chloride goes together, that's why, predominantly extracellularly. We have the phosphate ions over there, the bicarbonates here, and the sulfates. Now the phosphate, as you can see here, the phosphate ions is predominantly intracellularly, and perhaps this is related to the presence of proteins or ATP also, okay? We also have some organic acids, low molecular weight organic acids, and of course proteins here are colloids. These are colloids. So this is the only molecule that is included in this table that is a high molecular weight one. And finally, non-ionic solutes present in body fluids predominantly glucose, 5.6 milliequivalents per liter. Of course, when you usually detect or report the glucose concentration in the blood, you report it as grams per dl. But in this case, I just wanted the units to be uniform throughout the table. Okay, so let us now move to the explanation of terms here. I have already described the electrolytes. These are the ionic solutions, okay? The term crystalloids it basically includes electrolytes and some of the other non-ionic low molecular weight solutes that are present in body fluids, not proteins, okay? Now, what are the properties of electrolytes? We are already familiar with some of them, but let's refresh our memory. So ions can pass readily through capillary membranes, and that includes the capillary endothelium of the blood, right? Due to their small size, but not through plasma protein membranes. So this is why the composition of interstitial fluid is similar to the composition of intravascular fluid, similar to the composition of blood with respect to electrolytes, okay? We also remember that these are osmotically active species, and as such, when they move into different compartments, water moves with them. Remember the phenomenon of osmosis, right? Especially when the membranes, the plasma membranes, are impermeable to ions. So ions will not be able to move intracellularly, but if they exist at higher concentration extracellularly, water has to leak out of cells and dilute those solutions. So this is the complication here, and this is the interplay between fluids and electrolytes. Now, we have already discussed the term crystalloids. It's broader and it's actually an unfortunate term, I believe, but it is there and you need to be familiar what is crystalloids. In addition to electrolytes, it also includes other low molecular weight compounds like dextrose here, okay? Now, the only non-ionic molecule that is used to adjust tonicity of solutions, to my knowledge, is dextrose. Everything else, non-ionic, right? That's the only one that is commonly used. No other non-ionic molecule is commonly used to adjust the tonicity of solutions to isotonic aside from dextrose. Now let's move now to some of the properties of colloids. As we mentioned, these are high molecular weight. So high molecular weight molecules, usually let's say proteins. Okay. They form colloidal solutions. So these solutions, they are called colloidal because they are not true solutions in the sense that because these molecules, they have a very high molecular weight, these molecules have very long structure, let's say. So if this is a protein, and of course, let me just draw it more complicated one, it could happen that some of these segments may be hydrated by the solvent to a different degree. And therefore the solvation of these segments of the same protein may be different. That's why you can actually measure the particle size of these proteins in solution. They are not definitely dissolved the same way that small atoms or electrolytes are dissolving, or small molecules, okay? So they are larger size macromolecules, 3 to 20 nanometers. They cannot diffuse out of the blood circulation that easily, nor they could get excreted out of the body in the urine. Remember that our blood is filtered, right, in the kidney capillaries and through the Bowman's capsule. That's where you have the filtration and formation of the urine. These molecules are very big, and they don't go through the Bowman's capsule there. Okay, and therefore you never detect any proteins in the urine unless there is a disease or a severe condition. Okay, now because these colloids remain in the blood, not interstitial tissue, They have the capacity to sorb water out of the interstitial fluid and, of course, out of the intracellular fluids, and increase the vascular volume. And this is very important property of these colloids. Sometimes they are called plasma expanders. Again, because of their large size and their solvation properties, obviously, they have the capacity, they always stay in the blood because they're unable to leak out of the blood. And because of their capacity to get hydrated, they have the capacity to sorb water out of the cells and out of the interstitial fluids and increase the volume of the blood. Now here I have cited some of the conditions that can cause a reduction of protein concentration in the blood. So bleeding, internal and external, right? Since these proteins are in the blood, bleeding will cause a reduction of their concentration in the blood because you lose blood essentially, right? Also, other conditions that increase the capillary permeability, such as various infections that cause tissue inflammation, skin burns, could cause leakage of colloids, because here you have lost, essentially burns destroy the membrane barriers and everything goes through, okay? So these are all some disorders or conditions that can result in a reduction of colloid concentration in the vascular compartment and an abnormally large volume of interstitial fluid in some of these cases, not all of them, or in some of those cases you may actually end up eliminating protein in the urine if this infection involves, for example, kidneys. Okay, so here is what I have just mentioned before. Some of these colloidal solutions are used therapeutically to increase the plasma volume, the blood volume, and they are characterized by this so-called expansion index or expansion factor. What is this factor? This is a factor that denotes the capacity of the colloidal solution to increase the blood volume. For example, if a colloidal solution has an expansion index of 1.5, administering 1 liter of this colloidal solution would increase the plasma volume to 1.5 liters, okay? Now, here you have to be a little bit careful because the capacity of colloidal solution to increase the blood volume depends also on the disease treated and on the patient's idiosyncrasy. So this is something that we need to be careful. All right, so now we are moving to some of the conditions that can cause abnormal fluid shifts. And we start with loss of fluids. So loss of fluids can occur from vascular compartment because of internal or external hemorrhage, as we mentioned before, because of vomiting and diarrhea, and this involves the GI, right? Because of diuresis, that could be the result of actually drugs, and because of skin burns. This is just the most important ones in the list, okay? Now also the term hypovolemia is, the definition is a state of decreased circulating volume of blood plasma in the body due to significant blood or fluid losses as we described here. Now hypovolemia, of course, is frequently or almost always related to a decreased blood volume, okay, in the body, not the body volume, not body fluids, but blood fluids specifically. Now, contrary to the hypovolemia, we may have a condition that is called hypervolemia, and this is a condition that is characterized by an excessive fluid gain in the blood and in the whole body, and sometimes in the interstitial tissues, okay? Now, this condition is usually associated with problems regulating electrolytes, and specifically sodium. And it occurs more frequently with organ failure, for example, congestive heart failure. And when you have congestive heart failure, the cardiac output is reduced, and therefore the blood flow of other vital organs like the kidney and liver is compromised as well. And so this is how this is for about hypervolemia, that it occurs more frequently with organ failure like the heart, kidney, and liver, but also it could be a side effect of other medications, hormone imbalance, or excessive administration of IV fluids. So again, this is excessive fluid gain. Now here I've cited one example how an impaired liver function could cause reduced albumin synthesis. So this is the protein, right? And because of the reduced concentration of albumin in the blood, plasma can now escape from the central circulation and accumulate in places in the interstitial tissues, such as abdomen, causing ascites. So you see, I've cited this example here to demonstrate how complicated it could be. Impaired liver function led to a reduced albumin synthesis. Now you have less of proteins or colloids in the blood, so they cannot keep the fluids in the blood, and you have a leakage of these fluids and an accumulation of these fluids into the interstitial places, in this case abdomen, which is causing ascites. Okay, very, very complicated, but it's for us to read and understand. Now conditions, so here I've written this paragraph in red color to make sure that we do understand that serious electrolyte disturbances may lead to fluid shifts because of osmosis, and we're already familiar with the phenomenon of osmosis, right? So big losses of osmotically active solutes from a particular compartment will lead to fluid shifts out of that compartment, whereas a concentration increase of osmotically active species will lead, of course, to a fluid shift into that compartment. This is always true when there is no pathological condition, okay? Now, when there is a pathological condition, it could also be true. But when you have a disease state, the explanation or the mechanism may be much more complicated than just osmosis, okay? So you need to correct the pathological condition at the same time. Okay, so now we're moving to the diagnosis. Unfortunately for us, there is no single analytical test that could directly measure the volume of the extracellular fluid and compare it to the volume of the intracellular fluid. And this is one of the reasons why electrolyte and fluid imbalance are so complicated to treat sometimes. Now, we definitely, this is very important here, we can definitely measure the electrolyte concentration extracellularly. So this is one test that is definitely very informative, because you can directly determine the levels of electrolytes in the blood, and you can use it by comparison, of course, to determine whether a patient has a deficit or has an excess of electrolytes. Now, of course, because there is no single analytical test, a physician depends on many different tests and many different physical examinations, and the results and conclusions of those tests will be used in empirical equations to determine appropriate clinical interventions. And I've written some of these tests over here, okay? Now, what I've done in this lecture is the following. I have realized that there was really no rules out there that can at least stimulate or trigger a thinking process. And what I've done here is I've created a set of rules that are basically based on osmosis, based on whether a patient has deficiency of electrolytes or not, you could at least make a decision of the initial treatment. So let us take a look of those rules of physics in clinical intervention. And here make it very clear in the absence of electrolyte balances. You can use one of those three rules here to make an initial decision of how to treat a patient, let's say. And this is for fluid replacement. So if there is an increase in plasma volume, if you wish, actually here is the following. If you wish to increase the plasma volume, you can do that by administering an isotonic or a hypertonic colloid solution. Okay, and we have just mentioned this before, and to me it makes sense. If you want to increase the blood volume, the best way to do that, or one of the most efficient ways to do that, is by administering a colloidal solution, because colloids or proteins will remain in the blood vasculature. Okay, and we're gonna see, we're gonna get some numbers out, which are of course theoretical numbers in a minute. We're gonna see the figure 10.2 in a minute. Now, if you wish to increase the extracellular fluid, you can do that by administering an isotonic or hypertonic saline solution. Why is that? Because we know that sodium chloride, this is sodium chloride, right? Sodium and chloride are small ions. They are, of course, charged, right? So this ionic compound can be exchanged with the interstitial fluid, but it doesn't get passively diffused intracellularly. So if your intention is to increase both blood and interstitial fluid, so I'm just going to write intravascular fluid and interstitial fluid, then you can do that by administering an isotonic or hypertonic saline solution. You're going to see the difference between that. The important here, it has to be saline, right? It has to be ion that doesn't get inside the cell. And therefore, since you are increasing, you're administering solutes that remain into the blood and interstitial fluid, you should be able to sorb water into those two compartments, okay? Now, if you wish to increase the intracellular fluid and rehydrate cells, you can do that by administration of isotonic dextrose or hypotonic sodium chloride solutions. And of course, this should be straightforward for us. Why? Because dextrose does partition inside the cell, right? It does get actively transported into cells, and when it gets inside the cells, it will drag water in it. Well, definitely doesn't remain in the blood circulation or interstitial fluid. Also, why hypotonic sodium chloride? Why hypotonic? Of course, sodium chloride will remain in the blood, right? Or in the extracellular fluid. But since it is hypotonic, its concentration is much lower than the intracellular, right? And therefore water will be transported or will diffuse by osmosis inside the cell. So the hypotonic solution will become isotonic. See, like, these are very, very nice rules, and they do make sense. So at least now you can start thinking about, how do I fix the fluid and electrolyte imbalance? So these are our simple 3 rules, and again, I mentioned in the absence of any electrolyte imbalance. Okay, this is very important. And what could cause a fluid or electrolyte or a fluid imbalance if you don't have electrolyte imbalance? Well, that's a different story, but I can mention a number of things here. You may have an accident, right? Accidents. It could be collision, car collision. It could be war, like in war, right? I mean, there is no disorder behind that, but the patient just lost a lot of blood. Okay. Now here is what is exactly what I mentioned before. This is figure 10.2. So what would happen when you administer a colloid, 1 liter of a colloid? Since colloid, so we have, this is a normal individual, let's say 70 kilogram weight, right? So we have 3 liters of plasma. You administer 1 liter of a colloid. Colloid will stay there, so you have 5 liters. And notice that some of this fluid has now also moved out of the interstitial and out of the intracellular and accumulated in the plasma. Of course, this is a hypothetical scenario. The numbers are just representative here, they're not accurate. But this is what we expect to happen, okay? Now, what will happen if you infuse the patient with 1 liter of 3% saline? So this is obviously hypertonic, right? Hypertonic. So saline, sodium chloride, cannot diffuse intracellularly. So now you have a hypertonic solution, extracellular solution, and it will cause some of the intracellular fluid to diffuse into the interstitial fluid and of course in the plasma. So that's why we see an increase in the interstitial fluid volume and an increase in the intravascular volume or the blood. So this is a hypertonic 3% sodium chloride solution. Okay. Now what would happen if you infuse 1 liter of D5W? Now dextrose can get inside the cell. So you're infusing an isotonic. This is isotonic, right? So this is isotonic. Some of it, of course, partitions into the cell, and therefore, because it is isotonic, it doesn't really cause any shifts, but you have administered 1 liter of excess, right? So this 1 liter is distributed. Let's say 0.5 went into the intracellular fluid, 0.25 remain into the interstitial compartment, and 0.25 remain into the blood. And again, this is because you gave an isotonic solution, and because it is isotonic, it didn't cause any shifts of fluids from the body compartments. Unlike the situation here, which is hypertonic, you gave hypertonic here, you definitely cause a fluid shift from compartment to another compartment, okay? But not in this case. In this case, because you administer an isotonic dextrose, there is no body fluid shifts. But this isotonic solution, this volume, it is distributed into the 3 different compartments depending on where the solute is distributed. And as I mentioned before, dextrose gets inside the cells. That's why some of this volume, it ends up getting inside the cells. And again, the numbers are just theoretical here. Okay? So this solution can be used to rehydrate patients. And dehydration is usually associated with a reduced intracellular fluid. All right? Now, let us take a look of the difference between administering an isotonic sodium chloride versus a hypertonic sodium chloride, okay? So what would be the difference? Now, infusion of an isotonic saline solution should result in extracellular fluid volume increase, but not to the expense of intracellular fluid. Why? Because you gave an isotonic solution. The concentration of electrolytes is the same, and therefore there's no reason for osmosis. The concentrations are the same in both of these 2 compartments. But because you are administering a certain volume, the volume is going to be distributed mainly into the extracellular fluid. So there should be no fluid distribution between ECF and ISF. Also, so this is like, I should, okay, or intracellular here is really no difference, because first, the osmolarity of this solution is physiological, and second, the sodium concentration is very close to physiological levels of the ECF. Okay, so this is what I just mentioned before anyway. Now, there will be no convection of ions from the central circulation to the other body compartments, including interstitial, right, because it's isotonic. If there is no plasma deficit to start with, then the kidney slowly will remove the excess volume infused with time from the body. Okay, this is an additional point here. All right. So now let's proceed to how do we treat fluid and electrolyte balances in the presence of a condition or disorder. So here we do have an electrolyte balance. Can we use those rules, or do we need to modify them? Okay. So, and let me go back at this point and see those rules. So let's go back here. We said that you can increase the volume of plasma by administering an isotonic or hypertonic colloid solution, because colloids stay in the blood circulation and they sorb water from the other compartments. You can increase the extracellular fluid with isotonic or hypertonic saline, okay, because saline or sodium chloride stays in the extracellular fluid, they don't get inside the cells. And you can increase intracellular volume with dextrose, okay? Or hypotonic sodium chloride solution, and we have explained the mechanism here. All right, let's now discuss the cases where we have electrolyte imbalances. So in this case, the choice of the replacement fluids must be based on the pathophysiology of the disease state or condition. This is very, very important, of course. And the biochemistry and physicochemical properties of the therapeutic drug and the crystalloids. Because sometimes if this is a disease or a condition, you may have to administer a drug, right? So that's why I mentioned it there. Now, of course, to be able to treat or to remedy this electrolyte imbalance, you have to be able to understand the physiology behind this condition. And as I mentioned here, a very, very straightforward, common sense situation where the patient has lost a lot of blood. The best way to replace blood is to administer blood. Now remember that you can administer colloids. These are synthetic plasma expanders, right? But you need to understand that these synthetic plasma expanders are not hemoglobin. They have no capacity to carry oxygen. So restoration of the cardiac output using this solution is not equivalent to tissue oxygen restoration and organ shutdown could occur. So what I am saying over here is that yes, by administering colloidal solutions, you may be able to successfully replenish the vascular volume, but since these plasma expanders have no capacity to carry oxygen, you will compromise the oxygenation of vital organs perhaps. So the best way, if blood is available, administer blood. So let us take a look of this situation written over here. Consider, for example, a case where intracellular fluid is of lower osmolarity than the extracellular fluid because the serum sodium concentration is above the physiological levels, okay? So this is the case study. So cells have two choices. They can either dispose of water and shrink, or, and usually this happens, instead they may activate the sodium channels and increase the intracellular sodium concentration to match the osmolarity of extracellular fluid and avoid causing cell volume changes. So this is usually what cells will do, okay? They will not lose, they would not like to eliminate water from their cell volume. They would rather compromise the loss of water by capturing more sodium ions. Remember that what's important is the concentration. So as long as they can tolerate a little bit higher concentration inside the cell, they will do that. So by activating sodium channels, they will increase the ICF, sodium concentration, and that would avoid causing cell volume changes. Let's take a look of another very, very important case over here. So here what we have is a case of serious hypokalemia that can be treated with IV infusion of KCl solutions. Okay, so this is what we usually do. Now, of course, you cannot adjust the tonicity of these solutions using just potassium chloride, because this concentration is going to be too high, and of course you're going to cause a heart attack to patient. The patient is going to die. You have to adjust the tonicity of these solutions with addition of sodium chloride, but don't even dare to use dextrose. Okay, you shouldn't use dextrose. Why? Because dextrose in the blood stimulates secretion of insulin. Now, binding of insulin to its receptor increases the activity of sodium potassium ATPase and mediates increased transmembrane transport of extracellular potassium ions into skeletal muscle cells. As a result, the potassium serum levels would remain low because it gets potassium inside the cells. So therefore, the patient has hypokalemia, you are administering potassium chloride to replenish the levels extracellularly, but because you adjusted the osmotic pressure with dextrose, dextrose is causing the release of insulin, which causes potassium to get inside the cells, so eventually hyperkalemia is not going to be treated. So you shouldn't do that. This is exactly the reason why acute hyperkalemia, notice that, is treated with insulin injection, because insulin gets potassium inside the cell, out of the extracellular compartment of the blood, followed by an IV infusion of 50% weight per volume dextrose solution to avoid a hypoglycemic event. Notice that this is hypertonic, right? Very, very important case. This is to show you that electrolyte and fluid imbalances can be very, very complicated. So regardless of the therapeutic fluid, IV infusion should be done at a very slow rate, especially if the condition responsible for the electrolyte imbalance has been there for a while. And this is one case that I've cited here of a chronic condition. Brain cells, for example, are particularly sensitive to abrupt osmotic changes. In chronic electrolyte disturbances, brain cells adapt in hyposmolar or hyperosmolar environment, both ways, okay? By losing or storing organic solutes respectively. Attempts to correct these chronic electrolyte imbalances by rapid infusion of crystalloid solutions can lead to cerebral edema, herniation, and coma and death. So this is very, very important. Aside from one exception, IV infusion of these solutions should be done at a very slow rate. The exception, which we're going to study in the next lecture, is osmotic diuretics. When you administer osmotic diuretics, you need to get rid of excess fluid very, very fast. So you administer them in a very fast rate. And here we have now just one calculation. Example 10.2 is the only problem that I have included in this lecture. So let us take a look at what it says here. So based on the numbers given in figure 10.1, so in figure 10.1 it was for a regular 70 kilogram individual, okay, that the extracellular fluid is 13 liters, the intravascular fluid, so that's the blood or plasma, is 3 liters, and of course the interstitial fluid is 10 liters. So the extracellular fluid is composed of intravascular and interstitial. So 13 liters is the extracellular, 3 is the plasma, and 10 is the interstitial fluid. Calculate how much volume out of 650 ml of isotonic crystalloid solution administered intravenously will theoretically remain in the vascular compartment. What is the volume percentage increase of the interstitial fluid? Okay, so here we're administering an isotonic electrolyte solution, okay? So since it is isotonic, it's not going to cause any fluid shifts from these two compartments because there is no electrolyte imbalance here, right? And because it's an electrolyte, it doesn't go inside the cell, so everything remains into the extracellular volume, of fluid. Okay, so here is what I'm saying here. So that makes our task much easier. So here we're going to solve it in a way similar to the mixture problems that we've seen way back. So the key idea to solve this problem is the ratio of the interstitial fluid to the intravascular fluid, which stays constant after adding isotonic. Since there is no electrolyte imbalance here, the ratio of the interstitial fluid to the intravascular fluid, so let me just write it here, this ratio will remain as being equal to 10 liters over 3. So it's going to be 10 over 3. Before adding it, this is what you have, and after administering the 650 ml of isotonic solution, you will still have this ratio. There shouldn't be any change in the ratio of the body fluids, not the actual volumes, but the ratio should remain constant, okay? So I've written it over here. So the preserved property before and after addition of this is natural saline, okay, isotonic saline, is 10 over 3. And the final state, I'm adding 650 ml of isotonic saline, okay, and therefore the final volume is 13.65 liters. Now I'm substituting the preserved property into this over there. Okay, so we solve. So take a common factor here, take a common factor and solve for intravascular fluid, carry out the algebra, and you end up with 3.15 liters, and therefore the volume of saline solution distributed to the blood, to the plasma, is 150 ml. And of course the volume of saline distributed into the interstitial tissue is half a liter, right? That shouldn't be 1 there, it should be 650 ml or 0.65 liters. Okay, this is why I got a little bit confused there, but we figured it out. Okay, so this is what you have. Again, this is the preserved property. Substitute the preserved property into our final state equation there, solve for the intravascular volume. You find out the amount, the volume of saline solution distributed into the intravascular fluid, and then subtract it out of the 650 ml of sodium chloride administered, the isotonic one, and you end up with 0.5 liters of volume of isotonic solution that is distributed to the interstitial fluid. This is very nice, okay? Finally, I have included some practice exercises for you. The first one is really very nice, and it touches the concept we have described before, that sometimes or quite frequently the cells, instead of losing water, they prefer of actually taking in some of these electrolytes by activating some of the protein transporters. Okay, this is very nice here, and some of the more information is written here for you regarding the transporters. And here, which fluid composition has the greatest lasting plasma volume supportive effect, right? So this is about plasma volume, which one has the capacity to increase plasma volume. Obviously, compositions here that include compounds or molecules that can get inside the cells are not good candidates. And finally, here we have a nice exercise that involves liposomes. So this is a liposome is a delivery system that resembles cells without the presence, of course. And in liposomes, usually, always, what you have inside is aqueous solutions as well as outside. So this is a membrane bilayer, what you see there, of phospholipids, okay, bilayer. And you are asked to choose the right answer from there. This is a very nice, realistic exercise. And at this point, I would like to thank you for your attention. Until next time.